Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, do you have...
Mara, and it's wonderful to be with you again for a breakout session today. This session, health databases to track the early impacts and needs related to COVID-19. Was organized by Chris Krawczyk from OSHPD, California. Let's go ahead and bring Chris to the stage. Chris, it's good to see you today. Are you ready to go?
We are ready to go, Norm. Thank you.
Okay. Go ahead. The stage is yours.
Great. Thanks, Norm. And welcome, everybody. Good morning from California, or good afternoon for those that are already in the afternoon. I want to welcome you to our session today, our breakout session entitled Health Databases to Track the Early Impacts and Needs Related to COVID-19. We have 3 presentations today. The approach that we're going to take is I'm going to introduce the presentation, and during the presentation, we'll be keeping an eye on any questions or comments that are entered into chat. We'll take a little break in between each presentation to answer a couple of those questions, and then we'll make sure that we save time at the end for overall discussion and any other questions that come in. So without further ado, I'm happy to introduce our first presentation from Robin Gelburd with Fair Health, entitled Confronting a Pandemic Using National Claims Data to Trace the Arc of COVID-19 and Offer Actionable Insights.
Thank you for joining today's session. My name is Robin Gelburd, and I'm the president of Fair Health. In this presentation, we will review COVID-19's impact on the U.S. healthcare system and examine healthcare trends that emerged throughout the pandemic. For those less familiar with Fair Health, we are a national, independent, not-for-profit organization established to bring fairness and integrity to health insurance information. We were created out of a national desire for a standardized, comprehensive, and trusted data source to help all stakeholders exhale and have confidence in the information presented. We meet that need by having the largest collection of private insurance claims in the country and by being prudent stewards of that data. We now have over 34 billion insurance claims from 2002 to the present. We receive over 2 billion new claims each year. We are also a CMS designated national qualified entity and have been entrusted with the entire collection of Medicare fee-for-service claims, which accounts for another 37 billion claims. With respect to COVID-19, we recognize that Fair Health data could play a unique role in illuminating the impact of the pandemic on the healthcare system writ large. Accordingly, as the incidence of COVID-19 began to swell, during the first calendar quarter of 2020, we released our first study in March. The study projected United States costs for COVID-19 patients requiring stays in the hospital. At the beginning of the pandemic, there were no concrete claims data yet associated with COVID-19. The diagnosis code, which is directly associated with COVID-19, was established as of March 18, 2020, and many EMR and EHR systems were not outfitted to accommodate the virus until April 1st or thereafter. We were able to estimate the average costs that might be associated with COVID-19 by assuming similar patient care as found for patients who have a combination of influenza and pneumonia using ICD procedure codes and revenue codes. As seen in this chart, we found the total estimated charges per patient to be $73,000. With respect to in-network amounts, hospitals and physicians were estimated to receive about $38,000 per commercially insured patient in the aggregate. We released our second COVID study in May 2020. This study looked at the impact of COVID-19 on hospitals and health systems in the first quarter of 2020 as compared to the first quarter of 2019, including the effects on estimated allowed amounts and facility discharge volume. The brief also detailed differences between the Northeast, which was hardest hit at the time, and the nation as a whole. We were able to estimate charges and changes in the facility discharge volume by comparing 2020 to the same months in 2019. From March 2019 to 2020, in the Northeast, small and mid-sized facilities both declined 34% in discharge volume, with large facilities dropping 40%. Since the Northeast was particularly hard hit at the beginning of the pandemic, we saw similar decreases in discharge volume at the national level. We continued our COVID-19 research with a third study released in June. This study focused on the impact of the COVID-19 pandemic on healthcare professional utilization and revenue. It highlighted 7 distinct specialties. To evaluate the change in professional service utilization, we compared 2019 to 2020 for each month. Within March, across all regions and nationally, the decrease in professional services proved significant, ranging from 69 to 76%. Our fourth brief examined key characteristics of those patients diagnosed with COVID-19. We striated the data by age, gender, rural versus urban area, the venue of care where the patient was first diagnosed, the comorbidities of those hospitalized with the virus, and the median cost of hospitalization. At the time the study was published, we found that nationally, between January 2020 and May 2020, COVID-19 was most commonly associated with individuals between the ages of 51 to 60. We also found that COVID affected both males and females relatively equally, with both genders seeking care at a similar rate. We released our fifth COVID-19 brief in September 2020. This study evaluated the impact of the pandemic on the dental industry by comparing dental service utilization in the first 6 months of 2020 to the first 6 months of 2019. We placed special emphasis on March and April 2020, when the pandemic was rampant and many dental practices were closed, and June 2020, when many dental practices had reopened. Our study found that the dental industry underwent severe declines in utilization in March and April 2020. Use of dental services fell 75% in March and 79% in April compared to the same months the year before. These were months when the COVID-19 pandemic first became widespread in the United States, and many states banned elective dental procedures. In May, many of these bans were lifted and dentists started reopening their doors, but there was still a 27% drop in the number of procedures performed in May 2020 compared to May 2019. By June 2020, there was actually a 1% increase in utilization compared to June 2019. Our next COVID-19 study, released in November 2020, showed the relationship between pre-existing comorbidities of COVID-19 and mortality in privately insured patients. Relationships were examined between the outcome of mortality and age, gender, and pre-existing conditions. The results of this analysis were used by a number of jurisdictions, public health officials, and patient advocates to help inform protocols for vaccine prioritization. Our studies showed that COVID-19 patients under age 70 had greater odds of dying if they had any of the 10 comorbidities shown on this chart. The highest risk came with lung cancer. COVID-19 patients with developmental disorders followed closely behind. In fact, COVID-19 patients with developmental disorders carried the highest risk of mortality across all age groups. For our 7th COVID-19 study, released in March 2021, we evaluated the effects of the pandemic on pediatric mental health. Defining the pediatric population as individuals 22 years old and younger, we tracked month-by-month changes in pediatric mental health from January to November 2020 compared to the same months in 2019. Our analysis found that as mental health claim lines increased for individuals aged 13 to 18 during the pandemic, telehealth outdistanced an in-office setting for mental health treatment among this population. In January and February 2020, prior to the spring wave of the pandemic, mental health services were overwhelmingly rendered in an in-office setting. But in March and April, when states banned non-emergency medical visits and patients avoided in-person care for fear of infection with COVID-19, telehealth increased as a venue of care for mental health services among 13 to 18-year-old patients. This growth in telehealth utilization during the COVID-19 pandemic has also been an area of particular focus for Fair Health. To help illuminate the state of telehealth during the pandemic, Fair Health launched the monthly telehealth regional tracker. The telehealth tracker is a free interactive feature on our website that tracks how telehealth is evolving from month to month in all 4 US Census regions and nationally. Our data showed that telehealth utilization expanded greatly in 2020 as patients and providers sought a venue of care that would reduce the chance of transmitting COVID-19. Here we are reviewing telehealth data from January to February 2021. As you can see, telehealth claim lines fell as a percentage of total medical claim lines, 15.7% nationally. This decline coincided with the national drop in COVID-19 cases and increasing vaccination rates. Telehealth utilization continued to fall nationally from February to March 2021. Telehealth claim lines fell 5.1% nationally as a percentage of all medical claim lines, decreasing from 5.9% of claim lines in February 2021 to 5.6% in March. In April 2021, telehealth utilization fell nationally for the 3rd straight month. Telehealth claim lines declined 12.5% nationally as a percentage of all medical claim lines, decreasing from 5.6% of claim lines in March 2021 to 4.9% in April. The decline in telehealth utilization appears largely to be driven by the return of non-mental health services from telehealth, where they had shifted during the COVID-19 pandemic to in-person settings. In June, Fair Health released its 8th COVID-19 study on post-COVID conditions. Although many patients recover from COVID-19 within a few weeks, some exhibit persistent or new symptoms more than 4 weeks after first being diagnosed. We studied nearly 2 million COVID-19 patients over the period from February 2020 to February 2021 to help shed light on this emerging issue for patients, policymakers, providers, payers, and researchers. Given the size of the cohort studied and nature of the findings, we were invited to present our statistical analyses to a working group on COVID-19 vaccines at the World Health Organization shortly after the study's release. If you would like to review any of the resources discussed today, you can download Fair Health's presentation and find them linked on this slide. Thank you. I look forward to your questions after the other speakers have concluded with their presentations.
Okay, thank you, Robin. We did receive a couple of questions in chat. I want to thank folks for submitting your questions and comments. I think we have just about 2 minutes here, so maybe if we can take a minute for each of the questions. The first one is, did you try to tease out pre-ICD code data to pick up on cases before April 1st? And if so, what did you look at?
So as indicated, the official codes for COVID-19 were not established until March 18, 2020. So to really try to provide some window into costs associated with the pandemic, we looked at some comparable data associated with flu and pneumonia and tried to give some type of working estimate. We're really excited. Within the next 2 weeks, we are going to be launching a new interactive free service on our website, fairhealth.org, that will allow all visitors to see by state the different levels of costs associated with outpatient services, with general hospitalization, and then with complex hospitalization involving ICU or ventilator needs. So it'll be a very detailed look now adopting the new codes that have been established.
Excellent. Great. Thank you. And then second question, also ICD related. How would the implementation of new ICD-10 CM for COVID and update to the DRG algorithm impact your longitudinal comparison using older influenza DRGs in your reports? And would there be an underreporting of the costs?
There wasn't necessarily an underreporting of the costs, but obviously with the official codes now being widely adopted by both physicians and at the facility level, we were able to really refine those estimates and break it out by a number of specific services that were unique to COVID, separate from flu and pneumonia, which is why we're really excited about providing this new updated window, because there's been such a huge appetite in learning what the resources are associated with treating this condition.
Thank you. And then the last comment that we had actually was just a request to share the website for the telehealth tracker. And there you go. There's the address. It has also been entered into chat and will remain there as we continue through our session today. But I want to thank Robin for her presentation and for answering a couple questions. We are going to move on to our second presentation. And again, keep the chats and the comments coming. We will be tracking those, and time permitting at the end, we'll return to additional questions and discussion. But our second presentation today comes from Mary Beth Conroy and David Williams from the New York State Department of Health. And their presentation is entitled Flattening the Curve: How Robust COVID-19 Hospital Admission Data Informed Policy.
Hi, good afternoon. Thank you for attending. My name is David Williams. I'm a research scientist at the New York State Department of Health, and today's presentation is on how robust COVID-19 hospital admissions data helped inform policy in New York State. The points that will be covered include policy milestones in New York State, data collection through the Health Electronic Response Data System, HERDS, findings, leveraging additional data sources, and technical challenges encountered along the way. This is a look of COVID-19 hospital admissions in New York State since the beginning of the pandemic. New York State was impacted early on. You can see the peak in April of 2020, and a second but smaller peak occurred in January 2021. And you can notice that the decline in admissions after the second peak coincides with the release of vaccines in New York State. This is a look at a timeline of events throughout the pandemic. State of emergency was declared in New York State, and the state was placed on pause in March of 2020. All non-essential businesses statewide were closed. Non-essential gatherings were canceled. Social distance practice were implemented, and sick individuals cannot leave their homes unless to receive medical care. And these were just some of the parts of pause that were implemented. At the same time, the New York State data collection system was implemented using HERDS as the data collection platform. Shortly thereafter, in April, New York State had the highest COVID-19 positivity rate globally. And in May, additional variables were added to HERDS to collect patient information about occupation and method of travel to the occupation and where the patient arrived to the hospital from. In November, the reason for admission was added to HERDS. In January 2021, vaccines were delivered to patients in high-need occupations, and by June 2021, 70% of New Yorkers received the first dose of vaccine, and the state of emergency was lifted. This is a simple schematic of the HERDS data collection process. It involves a process of the hospitals reporting to HERDS, the call center verifying with the hospitals, and the hospitals updating in HERDS, the data being sent to the analytic team for validation, and an iterative process back to the call center in the facility until the data is verified. Afterwards, data feeds were produced along with reports. These are the variables collected in HERDS. You can see it is a robust data source and includes patient demographics, admission and discharge information, along with hospital statistics for bed capacity, medical devices and PPE supplies, confirmed COVID-19 positive patient fatalities, and hospital staff vaccinations, and even more. And many of the variables displayed in the previous slide were used in the calculations to determine the phased-in regional reopenings. These include metrics 1 and 3 based on hospitalizations, metric 2 based on fatalities, and metrics 4 and 5 based on bed capacity. Now we'll take a look at some of the findings. This view shows where the patient arrived from, and you can notice since the beginning of the pandemic that the vast majority of patients arrived from their home, and the trend only continued to increase over time. This is a look at patients' age of new admits, and with the vaccine starting in January 2021, you can notice a decrease in the percentage of patients age 65 plus that were admitted to the hospital. The variables reason of admission and if the patient had COVID-19 symptoms at admission were added to HERDS in November 2020. In the graph to the left, you see the reason for inpatient admission, and a large percentage of patients are admitted specifically for COVID-19. The graph to the right shows the majority of patients are symptomatic upon admission. Two variables of particular interest early on in the pandemic was the patient's occupation and whether or not infected persons were using public transportation to travel to work. The view here shows the distribution of transportation methods to work, and you can see from the view that patients taking public transportation to work makes up a small percentage of admissions. And here's the view on occupations, and there was particular interest in whether or not frontline healthcare workers were infected. The bar graph to the left shows that most patients admitted to the hospital were not working. And the view on the right subsets down to essential workers, and it shows that the majority of essential workers admitted to the hospital were not frontline healthcare workers or first responders. Even though the HERDS data set is robust, we cannot answer questions like where the patient was being discharged or length of stay, to name a few. To do so, we leveraged the statewide planning and research cooperative system, SPARCS, an all-payer database to link the data. And the view here shows variables common to both data sets that were investigated for linking, and these variables include patient and facility identifiers and admission date. Deterministic matching was used to link the data sets. 9 matching rules were established, with the first rule being the gold standard, and each successive rule is less restrictive than the previous one. Age, admit date, and patient address were all allowed to have a margin of error at or below a specified threshold, and you can see these variables listed here are the actual variables used within the 9 matching rules. And as a result from the linkage, now we're able to take a look at the length of stay. And the view here shows that there's a shift towards 1 to 7 day length of stays over time. One of the major challenges that we encountered along the way was organizing and categorizing free text fields. This is an example of possible entries for patient comorbidities. You can see here that some entries contain coding and descriptives. Others are abbreviations, Some have spelling errors, still others have single strings of abbreviations. This was difficult to categorize and identify the different comorbidities. And the approach that was used is a machine learning approach to create an algorithm to mine the free text literal strings. After cleaning the values through the program, a manual review was done, and the program was updated over time. And over time, it improved greatly in identifying and cleaning the free text fields. And the same challenge existed for patient's occupation as well. The approach taken here was slightly different. Instead, all previous values for occupation were stored in a single data set, and the new values were manually reviewed and categorized. The new values were then added to the universe of occupations and used for the next day. And over time, the number of new occupations that needed manual review decreased. Moving forward, lessons learned. Data collection, validation, and turnaround on a daily basis presented enormous challenges. The infrastructure available to collect the data was flexible enough to be established and rolled out quickly. However, the changes to the data collection required in-depth technical skills and time and resources. The simplification played an important role in the efficiency of the process. Many free text fields were replaced with drop-downs. This eliminated the need for manual standardization. Also, automated visualizations for further lowered production time, turnaround times. And in the future, additional data collection infrastructure and software should be explored to edge closer to real-time reporting and also to limit resources. Thank you all for attending and look forward to questions.
All right. Thank you, David, for your presentation. And we didn't receive any questions in chat yet. I do encourage, again, folks to submit those for our discussion at the end. But your presentation, you mentioned linkages and that there were additional variables that were made available for the data linkage after the initial linkages had occurred. When those became available, can you elaborate on the additional analyses and on the linkage of those additional data?
Oh, yeah, sure. So some of the things that became available, we're now able to look at the patient's discharge disposition and see where they were discharged to. As mentioned previously, we can take a look at the length of stay as well. One of the really interesting views that we can look at now is the distribution of the principal diagnoses and how those trends changed over time. Also, we now have the different procedure codes available to us, so we can look in to see which procedures were performed. And another real benefit of it is the ability to be able to verify and validate the data that's coming in from one data source against another data source. We can confirm the concordance between different patient demographics, comorbidities, admission source. So it really acts as another validation method to confirm that the data that we have coming in is good data.
Okay. Excellent, thank you. And my apologies, we did actually receive a question in chat. My sidebar just here just didn't seem to update, but the question is, does anyone know of a study justifying higher Medicaid payments for hospital visits for non-COVID related diagnoses and treatments for patients having or having had COVID?
Off the top of my head, I'm unaware. Mary Beth, you may know?
No, I don't know of any studies on that.
Okay. If anyone in the audience actually does know of a study, please feel free to enter some additional information into the chat so that we can, again, as a community, share out information that may be out there. So I think at this point we're going to switch over. I want to thank again David and for his presentation, and David and Mary Beth for answering the questions. We're going to switch over to our third presentation in today's session from Manuela Staneva, entitled Not All Hospital Care is Created Equal, a comparative analysis of ICU and non-ICU COVID-19 hospitalizations in Mississippi.
Good afternoon. My name is Manuela Staneva, and I'm an epidemiologist for the Mississippi State Department of Health. I would like to thank NIDO for the opportunity to present our work. The title of our presentation is Not All Hospital Care is Created Equal, a comparative analysis of ICU and non-ICU COVID-19 hospitalizations in Mississippi. As we have learned, providing timely and high-quality critical care for patients suffering from COVID-19 has been crucial for saving lives during this pandemic. Hospital discharge data, a population-level data source, contains information on patients' demographics, diagnoses, procedures performed, resource utilized, and care outcomes. This dataset is a timely and cost-effective resource to study and monitor hospitalizations related to COVID-19. Our objective was to develop a conceptual framework for the long-term monitoring of COVID-19 associated hospitalizations requiring critical care. Our study population was Mississippi residents of 18 years of age or older with a primary or secondary COVID-19 diagnosis. We analyzed Mississippi's hospital discharge data for the period March 2020, March 2021, which is actually the latest available data. Defining critical care, we identified critical care hospitalizations using the Uniform Billing 40 revenue codes. And here lies the challenge of our study. Such codes are a heterogeneous group that include different types and level of intensive care, including intensive care units, coronary care units, and intermediate critical care, which are step-down care for patients with moderate severity of illness. In addition, critically ill patients may have prolonged stays and receive more than one critical care code. To generate mutually exclusive groups, we implemented an algorithm creating two distinct categories, ICU and ward care. Overview. During the study period, there were over 30,000 adult COVID-19 related hospitalizations among Mississippi residents. Of these, 71% were ward care and 29% were ICU care. As depicted in Figure 2, the percentage of ICU COVID-19 hospitalizations declined over time, albeit slightly. Demographics. One of the interesting findings was in the demographics for gender. The gender showed actually important disparities depending on the type of care. While more women were hospitalized in wards than men, the percentage of women and men was closer for ICUs. So these differences may signify that men suffered from more advanced COVID-19 illness prior to their admission, or that these groups just had higher comorbidity burdens. Some of the other demographics we examined are age groups, race, payer, and residence. As expected, the vast majority of patients hospitalized for COVID-19 were elderly, people who were above 65 years of age. There weren't many differences in the age distribution between ICU and ward care. Overall, more whites than African Americans were hospitalized during this study period. Again, no many differences between ICU and ward care. Another interesting finding was the distribution by residents. Interestingly, in Mississippi, over 60% of COVID-19 hospitalizations were among rural residents, something that we have started to call the forgotten disparity. And lastly, again, as expected, the distribution of payers was similar, with nearly half of COVID-19 associated discharges covered by Medicare. However, our most important finding was related to in-hospital mortality. Among patients hospitalized for COVID-19, the overall in-hospital mortality was 14.7%. However, this outcome varied by the type of care provided, from 5.8% for patients in wards to 37.2% for patients in ICU. And when we looked at patients hospitalized in ICU, but also put on ventilator, this percentage was even higher. Resource utilization. Compared to patients in other forms of care, ICU patients consumed a greater amount of invasive procedures, hospital resources, and had longer hospital stays. As depicted in the figure, almost half, or 43.3% of COVID-19 ICU patients were put on ventilators. The mean length of stay for COVID-19 hospitalizations ranged for 7 days for ward patients to 13 days for ICU patients. Higher rates of resource usage meant that mean hospital charges were higher for ICU patients compared to ward patients, actually much higher. And this is the end of our presentation. I would like to introduce my co-author, Dr. Thomas Dobbs, who's also the State Health Officer for Mississippi, and actually show you the practical value of this or similar type of studies with hospital discharge data. In Mississippi, we try to be very timely with our analysis of this discharge data, and we will just produced 2 public health reports, including some of the data you just saw, and this is an example of a table that went on social media and was met with quite of interest. And with this, I would like to conclude my presentation and to thank you for listening to this presentation.
Thank you, Manuela. Unfortunately, we do have some technical difficulties, and as a result, Manuela is not going to be available to answer questions directly in the session, but displayed on the screen is her contact information. Please feel free to reach out to her directly with any questions that you may have. So we do have about 20 minutes left in our session, so we are going to bring up all of our presenters from today that are available. And engage in just a little bit of our own question and answer session. If, again, participants in this session have questions that they want to enter into chat, we'll work those into our conversation. But Yeah, the session was focused on the early part of the pandemic and the early response and using data as a part of the early response to the pandemic. Robin, you identified a large number of studies and uses of the data. I'm curious, what additional research has Fair Health been doing, and what's next? What are the next areas of Fair Health's research efforts?
Sure. So we're really pursuing sort of three prongs of research. Two relate to sort of ongoing work we've been doing in the telehealth space, and I'm glad the telehealth tracker information was provided. When we first launched the telehealth tracker, it was really juxtaposing 2020 with the same month in 2019 to really see that really monumental change that went on in the healthcare system. As we moved in 2021 and we started looking at month-to-month changes, as we started moving outside of the heat of the pandemic, we're now seeing month-to-month drops in utilization. So that's ongoing, and our next telehealth tracker comparing July to June will be released next week. Our next really major study is looking at breakthrough cases. That's something that people have been asking us about given the breadth of data that we have. So we are going to be looking at a cohort of individuals who have been fully vaccinated and then at least 30 days out receive a COVID diagnosis compared to those who are unvaccinated. And then we will also compare their sort of migration through the healthcare system once vaccinated, juxtaposing the breakthrough cases with those who have been unvaccinated to see whether there's more outpatient or asymptomatic cases, for example, in the breakthrough cases, compared to hospitalizations that may be occurring with those who've been unvaccinated. And that study should be released sometime in November.
Excellent. So right there, actually, hit on some interesting topics and some topics that are going to be the focus of some other presentations during NADO this year, in particular telehealth. Telehealth has been a very interesting topic. And, sort of, again, the increased utilization of telehealth as a result of COVID. In relation then to the sort of drop and reduction or decline in-person services. And again, I think we saw that, in a number of the presentations today is that drop in the utilization of services. Do any of y'all want to kind of comment on, just again, that drop in services, the impact on access to care and on patient outcomes beyond just what was seen in the presentations today?
Sure. So what we're seeing in telehealth during the pandemic, what we did see was the introduction of diagnoses and conditions presenting in a telehealth setting that prior to the pandemic, you would not see. For example, joint soft tissue diseases, hypertension, developmental disorders. Whereas before you would see more, urinary tract infections or dermatology issues and so forth. We're seeing a return more to the pre-pandemic conditions, except with mental health. Mental health seems to have real staying power in a telehealth setting. And we're seeing sort of persistent utilization in that regard, particularly with those 22 and younger. So it's providing a level of access for those that may not have previously reached out for care. So we're tracking that closely to see also under the umbrella of mental health conditions, what the specific diagnoses are, because those vary depending on what age cohort you're looking at. And just one last thing in terms of asynchronous health, we are seeing people taking more advantage of technologies that allow their care to be tracked. And that's particularly helpful for the older population or those in rural areas where it's difficult to get back to an acute care facility post-discharge. So that we are tracking as well.
Excellent. Okay. We do have a couple of questions that are coming in through chat. So I'm just going to go ahead and ask the first one that I see here, which is, can you all talk a bit more about the data sources they used for this work? The person that submitted the question said that in their state, you would need to connect multiple different data sources, both within and without the State Department of Health.
Is that directed at Fair Health or to the folks in?
Why don't we start with New York and start with David? Oh, David, you're on mute.
Oh, thanks. Sorry about that. Yeah, so the different data sets, the first data set that we established is the HERDS data set. And this data set was actually set up specifically for COVID and originally it was set up where the facilities were entering data twice a day, and we were reporting back as we were hit so hard in the beginning and had the highest positivity rate globally. It went down to a daily intake where the facilities would report daily, and we would process as well. And so I mentioned earlier all the different variables that does include, and it does include many, including comorbidities. It is on the patient level, so we have it's very robust. However, we also have an opportunity to use the all-payer database in New York, which is a claims database, where we can actually link the HERDS data based on different patient identifiers and be able to see all the additional variables that are included in the claims data. And so that's a huge addition of variables that we can actually look at and analyze. We do also have other data sources that are readily available that other people in our department have used to link the COVID database to as well. Mary Beth, do you want to elaborate on that a little more? Some of those other data sources that we use to link on?
Well, we use a number of different ones in the ecosystem, right? So we have our hospital discharge data, which David talked about earlier, which would allow length of stay, payment information, procedures, cost. And then we have fatality data from our vital event data. And and that's pretty much the two main. Oh, we also have our testing data. We would link to testing data. And that's pretty much the three that we link to. We link to testing and to vital events and to discharge data.
Okay. Thank you, David and Mary Beth. And actually, another question that came in for David is, which non-medical essential occupation types in New York had the highest admission rates / cases at the start of the pandemic?
The non-medical ones, we saw a large percent in like food service, related industries, is where we saw a large percent of the hospital admissions early on.
Okay, thank you. And actually, I mean, just again, sticking with David, since we have you in the queue here, there was a focus on patient occupation and travel method, and those in work, travel to work, were of particular interest in the pandemic. Why were these of such interest, particularly in New York? And then it appears like the results were kind of different from what you were expecting to see. Would you just comment on that?
Oh, sure. Yeah, so early on, it was nobody really knew how this was really spreading and how people were infecting one another, and they were trying to get a better understanding of that. And one of the ideas that was suspected was that there would be a lot of people that were working that were making up a large percentage of the new admissions, and also that we would see that patients traveling to work using public transportation or car services would also make up a large percentage of new admissions. And we actually just didn't see that in the data. It was the number of, or the percentage rather, of new admits. The majority of them were from people that were either working from home or retired, or not working altogether. And the public transportation had just made up a very small percentage of the travel methods to work.
Thank you. So, again, our session focused on, the response to the early part of the pandemic. And, I'd asked earlier to Robin, what lies next in their research, sort of at this point, looking at, what's emerging now and where the pandemic might go in the future. But in hindsight, looking back now on, everything that has been learned, all the technology that's been put in place, this opportunity here at this point in time, as a result of COVID, what in hindsight, would you have maybe hoped was already in place? Or, again, in terms of what's emerged now, questions that you maybe wish that you would have began looking at, earlier in the pandemic?
I would say that in the beginning, it was a very difficult process to communicate back and forth with facilities, especially on a twice a day basis. So I wish we had just some better contacts set up in advance to have a point person. So that was definitely a difficulty early on. And then the other thing that we progressively got better with was taking free text fields and standardizing them into drop downs. So that way we weren't data mining free text fields using advanced analytics and machine learning and whatnot. So I think that was a big help, actually just standardizing the process of it. And really, I guess one of the great things that came out of it was being able to work with so many different people, so many different analysts, and have all the analysts bring their ideas to the table and really collaborate to really try and refine the process and make it more efficient, more timely, and make it validated and make it very accurate.
Thanks. Robin, same question to you.
Well, in some ways we were fortunate because we take in 2 billion claims a year. We have standardization processes. So from our different sources, we were able to map very quickly and compare apples to apples to allow almost for sort of a real-time window into the pandemic. I think while there was, a slight handicap in the beginning, as we noted, that certain codes didn't exist, it wasn't keeping pace with the claims coming in. So we probably, in the beginning of 2020, from that January to March window, we probably lost some critical insights into the pandemic because there were no ICD-10 procedure codes. I think we caught up pretty rapidly, and I think the professionals, at the provider level as well as the facility level, kept pace as soon as those new official codes got out of the gate. So I don't think the public was hurt in any way.
Okay, so thank you. And another question that has come in through chat for David is, can you comment on how much of the linking was developed just for COVID, or had you or others in New York State done similar work before?
So we have done similar work for it. So we did use that as a backbone to be able to build it rather quickly. The linkage that we did was specifically for COVID, but we could bring in the previous code and the previous methodologies that we've used in the past in order to be able to set it up in a very short amount of time.
Okay. And then also, there's been a question expressing interest in the New York State data. Is the data available for researchers outside of New York State agencies?
The HERDS data, much of it is reported as an aggregate, one on a daily basis, and there's a lot of great data on Health Data New York for public downloads that is available to the public, and then also as far as the Sparks database, that is available. You would have to request permissions in order to be able to access that data.
Okay. And do they make that request through Health Data New York? Or maybe we can get a link entered in the chat, or how would they go about making that request?
Mary Beth, do you have
for Sparks, for the Sparks data?
Yes.
Yeah, that would it would be the link on the main health.ny.gov, and then just put in Sparks, and it will come up and it will say data requests. And it gives a whole section on the governance and what's needed there. And the Health Data New York files, New York is committed to being transparent in putting out accurate data to inform. There is testing data on Health Data right now that provides new cases, total cases, and new total tests that can be downloaded. There's also information on fatalities that occurred within facilities by age group, by gender, and there's information on hospitalizations. And that has been put out there where we did start collecting in mid-March. the data did not really become reliable and solid because of the hospitals getting used to the new reporting structure of this survey till right around March 26, 2020. So most of those files start on March 26, 2020. And I think another thing that's important to note is that whereas, most data sources rely on a national standard, such as the claims data and the encounter data, and that's why it's able to be mined quicker because it is a national standard with set codes and values. A lot of what we had to stand up was unstructured data, and and the hospitals were typing in, work at Applebee's or, bus driver or, some of those things. So a lot of what we did in order to inform the public while we were in pause, actually, we were informing a lot of the reopening metrics. I don't know, a lot of people remember, but New York did a phased in microcluster approach to reopening. And there were a number of different metrics that had to be informed. And some of those, the way that we informed it had to be unstructured data. And so David talked a little bit about the machine learning protocols that they put in place to standardize the data to get it in a usable structure to inform and put out a lot of the press releases. The data would come in at night, and usually the press releases to inform New Yorkers and eventually the nation. A lot of people started across the nation were looking for information on COVID, how this was spreading, with people in pause, how were cases still going up? And, it had to be right. And it had to be fast. So they really did pull together, as David said, a multidisciplinary team pulled together to get that data put in, validated, put into a format that could go into a slide deck to inform the public, and also QA'd all in the middle of the night. So, but to answer the question about data available, yeah, we make as much as we can that we know is reliable, and we know that was informed. And also, we have a number of different dashboards. We have the vaccine tracker, and we have the COVID-19 tracker, and also the National Center for Health Statistics publishes downloadable files on fatalities across all areas for New York State that you can access from that site.
Thank you, Mary Beth. Certainly a lot of work, a lot of effort, resulting in a lot of information and a lot of data. And it's great that you all do make the data available for others to be able to use. And last question, keeping an eye on time, is again for David. The New York State COVID data, they were updated twice a day, as you mentioned, at least initially. How often were you linking the live COVID data with then the other data resources?
How often do they do it? It was done at least on a weekly basis as we got later down the road, where they would match and link the data together, and we would also link it to the VS data as well, so that way we could see any fatalities that occurred after the hospital as well.
Okay, excellent. Thank you. So again, we did receive a question or two for our other presenter today, Manuela. Again, we apologize for the technical difficulty. We do encourage you to contact her directly if you do have any questions. And again, that contact information was presented in chat. It's going to be up here in just a moment, probably in terms of how to contact her. But we do want to thank all of our presenters for their presentations today. I want to thank all of our participants for attending today's session, for your questions, and hope that everybody has a great rest of your NATO conference. So thank you, everyone. Have a great day.
Thank you.
Thank you all.